Hello? That means they haven't heard me from the beginning?
You continue, I think.
Okay. So this is the incidence of breast cancer in Penang, and you can see that the peak is around the 40s to the 50s, and if you look carefully, there are people in their 20s with breast cancer, so that's quite alarming. So it's something to be aware of. Can't change slide. All right. So what are the risk factors for breast cancer? Okay, firstly is the family history. Anyone with a family member with breast cancer, and the closer they are, the more in number, the higher the risk. Of course, age is a risk. The higher the age, the higher the risk. Obesity is a risk as well. Early menarche or early commencement of menses or late menopause is also a risk. Alcohol and smoking is a small risk factor. Nulliparity means women without any children, or if they have their first childbirth at an older age, are also at increased risk of breast cancer. Patients with previous breast cancer are also at higher risk of developing another new cancer in the remaining breast. Certain conditions of the breast like lobular carcinoma in situ, atypical hyperplasia, these are conditions that increase the risk of breast cancer in the future. Those with prior radiotherapy to the chest given before the age of 30 has increased risk. And for those women who are undergoing screening mammography and find that the mammographic picture shows that breast density is high, they are at higher risk of breast cancer as well. Okay, what are the signs of breast cancer? Well, according to as you can see on my title, there is a lump in my breast. The most common sign is a lump. And most of the time, these cancerous lumps are painless, so they're not painful. So by far, that is the most important sign. Other in signs that is less common will be a discharge from the nipple, usually blood stain. Some cancers present with a rash in the nipple, and this rash is persistent, and sometimes after some time, the nipple can actually be eroded away. If you see a dimpling or swelling of the breast, changing of shape, retraction of the nipple, which is a recent onset, these are signs that we should watch out for. And lastly, pain. Yeah? Okay, I talked a bit about nipple rash just now. About 2% of breast cancer can present in this way, and if it's persistent, we should biopsy it. Yeah? This is a picture of Paget's disease, or some rash around the nipple areolar complex. This is a picture showing dimpling of the skin over here. This dimpling is due to the tumor or the cancer actually pulling in part of the skin and cause a dimpling effect. Pain is not a common feature of breast cancer, and pain is quite common for women during the menstrual cycle, typically occurring around the time of menses. And these are what we call cyclical pain. So cyclical pain is quite common and it's not a sign of cancer. But if a pain is non-cyclical, it doesn't follow your menstrual cycle, then it's something we have to be more aware of, and we look out for any other causes of that pain. Now, early detection of breast cancer is of utmost importance. With early detection, a lot of benefits can arise from that. But how do we achieve that? One is by public education, which is like what we're doing right now, to increase awareness of this disease, and so that the patients can look out for signs that will bring them earlier to their doctor. We encourage everyone to examine their own breast every month regularly, and above the age of 40, we will also advocate screening mammogram to be done every 1 to 2 yearly, combined with a regular examination by a health professional. Now, screening mammogram is done above 40 years of age, and it must be combined with a clinical examination by a doctor or a trained nurse. Yeah? And the benefits of screening mammography is to detect cancer early so we can treat at the early stage. With this, we can achieve a higher cure rate and also a higher chance of preserving the breast or not removing the entire breast as part of the treatment. So if mammogram detects something unusual or suspicious, how do we remove it? We have a method called hook wire localization, where with the help of the mammogram machine, a wire is inserted into the breast to the area of abnormality, and that can help us to locate where the abnormality is so that we can remove it for examination. For example, just to illustrate, this is an area of abnormality that we are interested in, and that is shown on the mammogram like here. So with the help of mammogram machine, a needle is placed and there is a hook at the tip so it stays in place, and the patient is then brought to the operating theatre. After the patient is under anesthesia, then we will operate to follow this wire in and remove the tissue that is at the hook, and then we will send this tissue to the X-ray department and get an X-ray done and confirm that the abnormality has been removed. Then we will send this tissue to the lab for histopathological examination. So the recommendation for breast self-examination starts from age 20. It should be done monthly. The best time to do it will be day 10 of the menstrual cycle. From age 20 to 39, some may want to get a health professional to examine every 3 years. But from the age of 40 onwards, it's yearly examination together with mammogram. Diagnosis of breast cancer relies on history physical examination that will let us know where the abnormality is, but we will always need imaging. Imaging that I've been talking about mammogram, but ultrasound is also a very good method to study the breast, and sometimes even MRI. If a patient has a discharge from the nipple, some of this discharge fluid can be collected and sent for cytology. This can help, but not confirmatory most of the time. To confirm a diagnosis, we need tissue diagnosis, and this can be achieved by a biopsy either with a needle or with a surgical biopsy where the lump is removed. Okay. There are many treatment modalities. Surgery is one of them, and then depending on the type of cancer, the stage of cancer, a combination of the other modalities may ensue. Like chemotherapy, radiotherapy, endocrine, and targeted therapy. As for the surgical therapy, if the tumor is very large, we still have to remove the entire breast. That's what we call mastectomy, and then we will also remove the lymph nodes in the axilla at the same time. That's axillary clearance. That's a diagram showing the entire breast is removed, and following removal there will be a scar on the chest wall. In breast conserving surgery, we remove the breast cancer with an adequate margin to clear the cancer. And as long as the margins are clear, we do not have to remove the entire breast, but the patient must receive radiotherapy to the intact breast. And this is a picture of a patient post breast conserving surgery where the tumor was removed from here and the lymph nodes from the axilla. As you can see, the shape is much better than a mastectomy. Not everyone can undergo breast conservation. Certain conditions will exclude the patients from this. Firstly is that if there are multiple tumors in multiple areas of the breast where we cannot remove in one incision, so we will have to remove the entire breast. Patients who are pregnant and who will require radiotherapy during pregnancy, they will not be able to go through breast conservation. Some patients have sensitive skin to radiotherapy and they can't receive radiotherapy, so they must have the whole breast removed. If somebody has a diffuse disease, microcalcification on mammogram that is suspicious, it is not advisable as well to conserve that breast. And of course, if we have removed the lump and the margins are not clear, which means that we are unable to remove the entire breast cancer from the breast. We will have to remove the whole breast. This is just an illustration to show that on the left here, the multifocal disease within the same quadrant, if it can be removed with one incision, we can still preserve the breast. But in a multicentric cancer, where you have multiple cancers in different quadrants of the breast, this patient will have the entire breast removed. Axillary clearance means removal of lymph nodes in the axilla or the armpit, and it's important to do this to know the stage of the disease as well as to control the disease in the axilla. And this will help us have more information about this breast cancer, which will then help the oncologist make a decision about further treatment. Chemotherapy is a medication that kills cancer cells. It is usually injected into the vein to kill cancer cells in the body. Okay, it can be given before surgery or after surgery. If given before surgery, the reason would be number one, either to make a cancer operable. Say if somebody comes with a very large cancer that cannot be operated, and after chemotherapy the tumor has shrunken to a smaller size, then it becomes operable, then we can remove the cancer. Or if a patient has a relatively large tumor but is operable, but we will have to do a mastectomy for her, and if she would like to attempt to conserve the breast, we can give chemotherapy to reduce the size to a size that we can try to conserve the breast. Chemotherapy is also used for palliative treatment of advanced cancer to prolong life, not for curative purpose. Radiotherapy, or the use of radiation to treat cancer, breast cancer, I've said earlier about radiotherapy being an essential part of a breast conserving treatment of breast cancer. So it forms part of that. Otherwise, there are also other uses of radiotherapy for palliative treatment, which means if a tumor is very large, it cannot be removed. Radiotherapy can give some palliation to reduce symptoms, especially if they have spread to the bone, which causes a lot of pain. Radiotherapy is a good form of treatment to reduce bone pain due to a spread of cancer. Certain cancers have hormone receptors on them, and if the hormone receptors are positive, then these patients will be able to benefit from endocrine therapy. The common one will be tamoxifen. This is to reduce the circulating hormones that may stimulate the growth of these cancer cells. Targeted therapy is a monoclonal antibody that targets HER2 positive tumors by preventing the stimulation of these cells by the growth promoting protein. So it is only recommended for use in patients with HER2 positive cancers. Treatment selection for patients actually is individualized. Every patient, we will have to look at the size of the tumor, the stage, the type of tumor, the hormone receptors, the HER2 status, to decide what is the best form of treatment for that particular patient. But in a summary, in the overview, early disease will tend to have surgery followed by adjuvant therapy. Adjuvant therapy will be things like chemotherapy to help to reduce recurrence. In patients with late disease, advanced disease, surgery becomes palliative. That means we do not do surgery up front. So it's a systemic therapy to treat the disease, and surgery only is reserved for palliation purpose. What about patients with stage 4 breast cancer? Stage 4 means very advanced, that a cancer that has spread to other parts of the body, other organs. The aim here is probably not to cure the patient, but to prolong survival. The mainstay of treatment here will be endocrine therapy if it is hormone positive, and also the control of bone pain, control of symptoms, and sometimes chemotherapy may be used as well. This is an article that I came across from BBC that has shown something very important, that sometimes even after 20 years after diagnosis of breast cancer, the recurrence can occur. Yeah? So it's difficult for us to tell a patient that you're cured of breast cancer until 20 years or so. Although after 5 years, if there's no recurrence, the chance of cure is quite high. Yeah? So what determines how curable is a breast cancer? Well, the size of the cancer is one. The larger the breast cancer, the harder to cure. Stage of cancer. The lower the stage, the better the cure rate. The grade as well. The lower the grade, the better cure rate. And the type of cancer here, like the hormone status, and there's another gene assay that helps oncologists to decide who are the ones more likely to develop recurrences in the future, and help to target those patients to give them chemotherapy. Okay, there are certain conditions of the breast. I put it as non-invasive breast cancer, but actually when it's non-invasive, it is not yet breast cancer. So these are the conditions that increases the risk of breast cancer in the future. So these are the two common conditions. One is a ductal carcinoma in situ and lobular carcinoma in situ. These are actually cancer cells within the ducts, and it has not invaded through, and it's not exactly cancer yet, but there are cancer cells that are seen, but they are walled up within those ducts. And so the goal of treatment for these problems would be to prevent occurrence of cancers in the future. And if there is occurrence of cancer, we hope that when we detect it, it will be still very early and localized to the breast. So the first one is ductal carcinoma in situ. This condition has been diagnosed more frequently after screening mammography, and it has increased about 3 to 4-fold. Okay, these conditions, they can transform to cancer, or about 30 to 50% chance over 10 years. And it is actually a precursor of invasive cancer. So the treatment of DCIS basically depends on how widespread is this condition. If it's widespread throughout the whole breast, then the treatment will be to remove the entire breast. If it's limited to one area, we can just remove that area, and sometimes we will give breast radiotherapy to the breast to reduce recurrence. What if it's palpable? If the lump is palpable for DCIS, we need to get at least 2 millimeter margin to be adequate. And this one is about radiotherapy for DCIS. I've mentioned earlier, it reduces recurrence rate by about 50%. So what is more likely to recur? If a DCI is palpable, we can feel it. If it's large, it's high grade, or involve one of the margins of the surgery, the excision biopsy, and if the age is less than 50, are more likely to recur. So the treatment should be mastectomy. It will be offered to those with multiple areas of DCIS. Lumpectomies or removal of just that lump may be offered to a smaller and low-grade tumors, and a whole breast radiotherapy should be considered to reduce recurrence. And if it's hormone receptor positive, then hormonal therapy or endocrine therapy should be considered as well. And if it recurs, it does depend whether the patient has already received radiotherapy. If they have already received radiotherapy, then mastectomy or removal of the whole breast would be required, because they cannot receive further radiotherapy. And if it's an invasive cancer, recurrence will be managed as a cancer. Okay, the second condition that is the non-invasive condition is a lobular carcinoma in situ. And this is a very interesting condition. Patients with this will have 10 to 20% risk of breast cancer over 15 years. However, the cancer can occur in either or both breasts. So it is not exactly a precursor of cancer. what it is actually a marker of increased risk of breast cancer. So how do we treat this condition? There's a choice between bilateral mastectomy, that means removal of both breasts to prevent breast cancer, or to closely monitor these patients and watch for any signs that we have to address. So I think most patients will opt for the close observation watch policy. Breast conserving surgery is not indicated in this because it's not actually a precursor of breast cancer. Okay, there are surgeries to reduce risk. Bilateral mastectomy means removal of both breasts. These certain conditions, certain genetic conditions may require it. Usually these patients have to go through genetic counseling before this can be done. Okay, there are some medications that can reduce the risk as well. As I've said earlier, those with ductal carcinoma in situ or lobular carcinoma in situ, if it's a hormone receptor positive, then certain medications like tamoxifen can actually reduce the risk. What about lifestyles? Reduce alcohol consumption, exercise, diet, weight control, encourage breastfeeding. These are things that you can do to reduce the risk of breast cancer. Okay, now about invasive breast cancer. Invasive breast cancer, there are two main types, ductal and lobular. Like I've said earlier, ductal are the ones that arise from the tubes that carry the milk, and lobular cancers are the cancers arising from the parts that produces the milk. Okay, Paget's disease is a very interesting disease. It's breast cancer that involves the skin of the nipple and the areolar complex. Okay, this is a picture of Paget's disease. You can see here the rash that is persistent and the nipple has actually eroded off. This is another picture of Paget's disease. Okay, phylloides tumor is a benign. It can be benign or malignant. It can be cancerous. It's not a very common tumor. When it is small, it appears very much like a fibroadenoma, which is completely harmless on ultrasound. But it tends to be more rapidly growing, and if it enlarges more than certain size, we should actually biopsy to make sure it's not phylloides tumor, because this tumor can potentially turn to become a cancer later on. So diagnosis is very important. Therefore, patients with lumps that appear like fibroadenoma or appear benign but rapidly enlarging, or if they're very large, more than 3 centimeters, we should actually remove them to make sure we're not dealing with phylloides tumor. And these tumors, when it turn into cancer, into a malignant phylloides tumor, most of the other treatment like radiotherapy, chemotherapy, they don't work very well on this cancer. So it's important to actually prevent it and remove these tumors early before they become cancerous. This is a patient with a very large left breast. Presented to me initially with unequal breast size rather than a tumor. And what she actually had was a very large phylloides tumor of the left breast. And this is a picture of intra-op surgery. This entire lump is actually the phylloides tumor, and luckily for her, it was benign. As for this patient, she actually had recurrence of phylloides tumor, and this time it's malignant. So this, unfortunately for her, is already spread to other parts of the body. A special note on breast cancer in pregnancy. We tend to favor needle biopsy for pregnant women because we want to avoid general anesthesia. And if it's confirmed to be cancer, then we will proceed with the treatment for breast cancer. We can still conserve the breast if the radiotherapy can be postponed to after delivery of the baby. If not, then we will have to remove the entire breast. Chemotherapy should not be given in the first trimester or the first 3 months or after week 35. Other than that, certain chemotherapy can be given during pregnancy. A special note on inflammatory breast cancer, which is not so common. These are very aggressive cancer that is associated with swelling and redness of the skin that covers the breast. We usually would start with chemotherapy, and if it responds, then we will go for surgery. These are not common, but they are very aggressive. Some patients present with just a lump in the axilla, and we made a diagnosis of breast cancer in a lymph node, but sometimes we can't find where it comes from. Sometimes we will use MRI, which is more sensitive, which may pick up a very small cancer in the breast. It is unusual to have this condition, but when it arises, we have a choice between removal of the same side of the breast where the lymph node is positive, or we just remove the lymph nodes and then we send patient for radiotherapy to the breast. A note on breast reconstruction. Breast reconstruction after removal of the breast can be either by using implants or autologous. Autologous means use your own body's tissue. Yeah? Usually it should not interfere with appropriate treatment for cancer, and because radiotherapy can actually damage the reconstruction, we usually would not advise to have the reconstruction done at the same time. So this is, I think this is my last slide to just highlight the nature of the disease of breast cancer. It's deadly if detected late, but with early detection and early treatment, it significantly improves the chance of cure, and there are many patients who are cured of breast cancer today. Yeah, and moreover, breast can be conserved and preserved if it's detected early. So now is a question and answer session. Okay, there's some questions. Okay, this is the first question that was asked. What is the difference between lump and cyst? Okay, a lump in the breast is generally refers to solid lumps. So if it's a growth, like a fleshy growth in the breast, whereas a cyst is basically just fluid in a lump. So that's the difference. Okay. Solid lumps can be benign, which is harmless, or it can be cancerous. Cysts, because if it's all fluid, it cannot be cancerous unless the lining of the cyst has some abnormal tissue. For that, we call it complex cysts, and they can potentially be cancer as well. Yeah. So that's the difference between a lump and a cyst. Okay, which one will potentially grow to be cancerous? Okay, both can potentially grow to be cancerous, but for a cyst it's quite unusual, quite rare, because usually there's no tissue surrounding the cyst wall. Whereas for a solid lump, like phylloides tumor for example, it can potentially become cancerous, even though in the beginning it's not. Otherwise, any solid lump, any other types of cancer usually arise even when it's small, it's already cancer to start with. Yeah? Do we need to control our diet? Actually, there's not very much you can do controlling your diet to prevent lumps and cysts forming in the breast. So, yeah. What is the size of lump and cyst that we need to remove? Okay. The need for removal doesn't really depend so much on the size. Of course, if a lump that doesn't appear like cancer but is large, like I said, it could be phylloides tumor, then we'll have to remove it. Anything above 3 centimeters, I would advise to remove it. Otherwise, even if a size is like half a centimeter, it's very small, but the shape looks suspicious, I will still remove it. So size is not so important. It's not a determining factor whether we should remove a lump or not, most of the time. As for cysts, most of the time we will just put a needle, aspirate the fluid. If the cyst disappears, then we do not need to operate. We will send the cyst fluid for cytology, and most of the time they will come back negative for cancer cells. So cysts in general is quite harmless. Yeah. Okay, so I think that's all. I'd like to thank everyone for tuning in. It's good to screen for breast cancer, detect it early, treat early, and then we have a lot of people who can be cured of this terrible disease, and which is becoming more and more often in our society, right? So thanks for listening.